Hey folks, Scott Weingart here, and this is an EMCrit podcast. Today on the podcast, I had a Twitter interaction with an anesthesiologist. You'll meet him shortly. And he basically, after I had done a podcast at the beginning of the year on Airway Update 2026, talking about the DAS Airway guidelines, and I talked about the assessment of a potentially difficult airway from anatomical and physiological perspectives. And he had written on Twitter the actual tweets, or I don't know what you call them, X's. The X's are in the show notes, but he had basically called my airway assessment recommendations outdated. And I told him he should come on the show and tell me why he thought that was true. And we had a very long debate. It was enjoyable for me. I don't know how enjoyable it would be for you, so I've heavily edited it. But whenever I edit a debate, I put the original there linked, so you can find that. If you really want to listen to the whole debate, or if anyone's accusing me of misquoting or cutting in a biased fashion, the entire thing's there, so you can listen to it. But I think I've gotten the true meat of the interaction. He is a primary progenitor of a app on Airway Triage, which I will discuss shortly, which I'm a big fan of. I had actually been using the app for educational purposes even prior to our debate, and I'll talk about why I think most people who love Airway will benefit from downloading that app. But we had a debate, and there were some areas of contention. I hope it'll be interesting. A lot of discussion about my vision of Airway philosophy and preparation and all sorts of good stuff around that. So if you like Airway, you should like this podcast. If you don't like Airway, it's going to be boring as hell. All right, why don't we roll right in? All right, so tell the audience who you are and what you do, Hans.
Yeah, nice to meet you all. My name is Hans Huytink. I'm an anesthesiologist. I'm based in the Netherlands. I've been in my profession for 25 years now, and I also work as a medical retrieval specialist. I fly fixed-wing air ambulances from the Netherlands and sometimes from Austria. I've also worked in academic centers and in different countries, in Melbourne and Australia, also in the Caribbean. So I've been around a while, and I like to do airway management, and this is the topic of today's podcast.
Absolutely. And now we've gone back and forth on Twitter on airway stuff, and you are the creator and proponent of the Airway Triage method,
yes.
And you actually have the Airway Management Academy as well. And these are both nonprofit organizations attempting to increase education and skill set in airway management.
That's correct. We have a network of international airway educators, and the goal is to increase global patient safety during airway management. And all the things we do are actually non-profit, and which works great because we are also supported by companies who supply equipment. And one of our projects is the Airway Triage application method. And I can tell you about this a bit more because it's the topic of this podcast. 10 years ago, Norskov et al. They published an important, I think, landmark anesthesia about airway assessment and how anesthetists assess the airway. And they found that the current airway assessment methods are not good enough. 9 out of 10 airways come still unanticipated difficult, and 1 in 4 is only predicted correctly. So even if you look at the patient with the current methods like Lemon or Malapati score or Army risk index, we are not good at predicting airway risk, and we end up in unanticipated difficult airway situations. And then after that article was published, I wrote an editorial, and with a colleague of mine, Professor Arthur Baumann, we came up with a new theoretical framework, and we thought, why are we talking about difficult airways? The airways are actually not difficult in itself. It's very subjective. And then we came up with a new method, and we called it Airway Triage.
Now, this Danish study that will be discussed repeatedly during the conversation is not a good study. I mean, it's a great study to suggest things, to prompt further work, but it's being used in this conversation as something to take the numbers from and actually consider them to be an objective truth in the world, and they are not. So what was actually done is there was in this Danish cohort study, an operative assessment was part of the patient's anesthesia record. And it was done before the case, and it was one of those checkbox things. It wasn't prospectively studied. It wasn't created for this. It was just built in to the Airway assessment of the operative assessment for these patients. And they asked, do you feel this is an anticipated difficult airway? And the default radio box was no. So anyone who wants to blow past these things, this was actually mentioned by the authors of the study, the answer would be no. If you just wanted to get through this as quickly as possible because you felt it wasn't helpful to your patients. And then they looked at what they could grasp retrospectively as to whether the airway was actually difficult or not. And what they deemed as a difficult airway was the use of a device beyond direct laryngoscopy or more than 2 attempts. And then they matched those two and they said, wow, look at all these doctors that predicted that it wasn't going to be difficult, but then it was. And as a result, first of all, since the anticipation, even glancing at this for a second, is that people are going to blow by this, then of course they're going to type no to everything unless they specifically did actually feel, oh, wow, this is like a real difficult airway. We're going to be doing all sorts of different stuff versus what you really wanted if you thought this study was going to be utile, which was that, oh, yeah, I'm still going to go ahead with direct laryngoscopy because I don't want to deal with the rigmarole. But yeah, this patient has some complexity factors that make it a bit harder. I don't know if any airway assessment was actually done at this point of looking at the chart. My guess is that this part was filled out. And then at some point, they actually looked at the patient. If the patient had any like gross anatomical difficulties or what have you, that would be assessed at that moment, past when this was being done. Or even if it wasn't, I lived with an anesthesiologist for 18 years. I know how it's actually done. And this study's not going to capture whether they thought it was a actual anticipated difficult airway or not. That it's just not, it's not realistic. It's laughable. I value this study being done because this is the kind of thing that like sparks your capability of doing real prospective trials. But this ain't it for what you actually wanted, which is to take numbers from how many unanticipated difficult airways. This study is not it. Their definition of what was difficult was completely confounded. If you decided you wanted to grab a video device just to show the resident in real time, you hadn't anticipated you were going to do that, but then you have a learner put with you and you grabbed a video laryngoscope. That's considered now a difficult airway. That would have been now deemed unanticipated difficult airway, even if it wasn't difficult at all. It was a super easy intubation. You just decided to use a video scope. There's so much. Like you could go and look at it yourself. Don't listen to any numbers you hear from this study in terms of how bad anesthesia is at predicting difficult airways. Beyond which, the whole thing I'm going to tell you in this podcast is, for the most part, unless something horrible is going on, unless the patient's super sick, unless the patient has gross anatomical distortion, most of the time in anesthesia, they will discover the airway is difficult in the midst of airway management, which is generally fine. The patients are fasted. The patients generally are physiologically okay. And if they're not, then they're in a different category in the anesthesiologist's mind. And therefore, if it turns out, oh yeah, this is harder than we thought, no worries. They'll just maintain that patient. A lot of times they'll see, I don't even think this is a good idea, but this is the way it's still done in most of anesthesia. They'll actually give the patient only their sedative agent, then see if they're even baggable before they give a muscle relaxant. All sorts of things make anesthesia practice not applicable to emergency and critical care airway. And therefore this study, even if it had validity, which it clearly doesn't, not applicable to our world in terms of unanticipated difficult airway prediction.
We triage airways into basic or advanced, and we try to find complexity factors to predict risk. So we don't predict difficult airways anymore, but we predict risk. And from there, we did an interesting prospective airway study, and we found airway complications in a 3-month prospective study at the academic center in Amsterdam, where I worked at the time. And we tried to find which airway complexity factors are really important to predict risk. And from there, we work from the theoretical framework and put it into an algorithm. And the algorithm will help you triage the airways. And from there, we said, okay, let's make an app. And that is how Airway Triage app was born.
All right, now I'm going to put in a plug for the Airway Triage app because you're going to hear me poo-pooing it throughout the rest of the podcast, yet I still think everyone who cares about Airway should download this app. First of all, they're a non-profit organization, so they're not doing this to make money. It's cheap. I don't remember what I paid. It was a couple of bucks in US dollars. It's nothing. And Hans, if you can't afford it, then just contact Hans or the Airway Triage app people, and I'm sure they'll work something out for you because they really care. They're just trying to get Airway education out here. The app it's chock full of educational material. My contention is it should not be used clinically in emergency medicine and critical care at this moment in time. Or maybe even like if you're a critical care trainee and you're not in a place where you're being supervised for your intubations, like you're just on your own, then I'd say this app is valuable clinically for you too. You probably should do it. But in my world, this app doesn't have clinical validity, it has educational validity. It's fantastic for that. So much good stuff in here. Highly advise getting it. Now, essentially, if you have time, it will have you do a checklist that will determine if an airway is basic or advanced, but we don't have time in emergency medicine or critical care for the most part. So you're going to be asked to do a help it categorization. I'm going to discuss that in detail as we go on, and that will tell you how complex the airway is. And I'll tell you why I don't think you need that, and therefore why I don't think you need to use the app clinically. But again, highly advised downloading for educational purposes. Let's actually contextualize this for the audience, how we got here. So I had done a podcast on the DAS guidelines and using that as a jumping off point for the state of Airway in 2026 for emergency medicine and critical care. Yeah. And I imagine you listened to just the beginning of that, which dealt with assessing for difficult airway as spurred by those DAS guidelines. And on Twitter, you then had said that my conversation was outdated as a spur for debate and interaction.
The assessment part, yes.
Yeah, absolutely. So that's how we got here. And so I think we'll have to evaluate that claim and see what comes of it. So tell me, Hans, why you think what I spoke about was outdated.
Yeah, the problem is you look into the airway articles and even the newest guidelines, and you will not find the newest information because it's not in it. Even the DAS, who does great things, they make guidelines, but they don't focus on airway assessment. They always focus on unanticipated, difficult airways. What do you do if you end up in trouble? But we move a step back and we look at the airways much better and closer and in a much smarter way. Because when I was trained, I had to look at anatomy, and then we checked patients, and then we also intensive care, we did physiology, and then they said, okay, you've maybe got the anatomically and physiologically difficult airway, and then you can start. But we look at 6 domains. I think if you assess an airway and do it really properly, and if you do it like an expert or people with really a lot of experience, they look at more domains. There are 6 domains. And one of the most important is, for example, human factors. We made a checklist. It's called the Help ET checklist. Every letter is a domain. Let's start with human factors. For example, if you are very tired, if you are working on call 23 hours and you have to intubate a patient at 6 o'clock at night, you should tell your team that you are tired because you are the risk factor. You are the complexity factor. That's one. So human factors is one domain. And in your assessment method and what you wrote on Twitter, I didn't see anything about human factors, I think. Then the second part is experience. That's the letter E. Experience is extremely important if you do an airway management procedure. If you're very good at the gyroscope or an LMAs and you have done it 1,000 times, you've got enough experience and chances are that you can manage your airway without any complications. So experience is important. If this is the first night on call in a new hospital and you just started your fellowship or your new job, you may be the risk factor in the team. So tell the team, I don't have enough experience if I do a video endoscopy, for example. Then we look at location, the L. Location of a procedure is of paramount importance. A basic airway is a patient with a normal airway, but if you have to intubate a patient out on the street or in a stairway or in the burning house or wherever, or in a CT scan, location is a complexity factor. So this is also important. Look at location. Then we got the anatomy domain, which is the P, patient factors. We all know it, airway syndromes, BMI, heart failure. I think that's also very important, but it's also in the part of physiology. But look at the patient factors. That's a long checklist. Then equipment. And maybe you need a flexible intubation scope, but your operating room next door has it, so you can't use it. So if you don't have the equipment, tell your team we don't have equipment. And the most important thing is time pressure. If you don't have time, you cannot make a strategy, you cannot call for help. So these 6 domains are important to look at. And that's why I called your assessment method a little bit outdated. And of course, I tried to start a discussion because we have to look at 6 domains. Not only on the anatomy, not only on the physiology. And if you look at the most promoted score, now the Makocha score, they also look a little bit at experience of the intubator. It's not enough. It's not enough. And that's why I call it outdated. And that's why we all should move to another and a better, I think, assessment method. And we should stop predicting the airways. We can't predict it. We should triage risk. That's the idea.
Yeah. So I guess the first thing I would say, Hans, is, and this is what I said on Twitter to actually bring you here, is you state that my method's outdated and I will continue. Oh, do I hate that sound? I know you hate that sound, but that is the sound you hear at the end of a paid episode in which you only get partial content. And that's because you're not a member of EMCrit. You are not an EMCritter, which means you're not getting all of the up-to-date critical information to help your super sick patients. Whether you're in the ED, ICU, or the pre-hospital environment, EMCrit will help you take care of your patients better. It's cheap, it's tax deductible, or you could get it reimbursed on your CME, and you're part of something bigger than just this content. You're part of the team. And we're going to have so much incredible stuff coming out in the next year. New things, new episodes, new forms of education, and you're not going to want to miss out on it. And while there is a ton of foam, there's a bunch of stuff that is behind the paywall. So please, please consider joining. Just come to emcrit.org/join. It takes 2 seconds, and then you will never have to hear this message again. But more importantly, you will be getting the cutting edge information to take care of your super sick patients. Scott Weingart for the EMCrit podcast saying bye-bye, and please come on over to emcrit.org/join. To state that I just disagree with your conceptualization of how this should be done in the environment that I work in. For the purpose of this discussion, we'll say that environment is resuscitative airway in the ICU or the emergency department. Now, there's so many different things to talk about here, so we'll see which order they wind up in. But the 6 factors that you say we need to assess, the reason they weren't mentioned is not because I don't think they're important, but because they don't really have relevance at the point of our decision-making in emergency medicine.
I disagree.
I know you do. So human factors is intrinsic to every bit of resuscitative interaction we do in emergency medicine and critical care. It's so intrinsic that we would never mention it in difficult airway assessment because it's already been transcended by the very environment we work in. And this is, I think, a fundamental difference between anesthesiology and emergency medicine and critical care. So there is a big difference in emergency medicine and critical care in that we go in with the assumption that things are going to be problematic. While in anesthesia, and you could speak to this having worked in both, the assumption is routine unless something tells you otherwise. So I cut out like 15 minutes of back and forth in which when I first broached this idea, Hans was very upset, telling me I didn't understand how it works in Europe, that anesthesia actually is doing emergency medicine and critical care, at which point I would tell him, I completely understand that. I have a bunch of friends doing exactly that. I already knew Hans was doing helicopter retrieval, emergency medicine, and anesthesia and critical care. Like, I know this. And what I'm still trying to get across is that there is a different mindset in anesthesia, not in anesthesiologists that do all of them, in anesthesia as a workplace versus emergency medicine and critical care. Hopefully I've made that clear. As the discussion got further in, I think we were on the same page on this finally, but at the very beginning it was kind of torturous and I cut all that out. So if you can't understand some of the context of why at some points it sounds like I'm pulling my hair out, that's why. So Human factors. We assume human factors are going to be difficult, and we mitigate as our routine in emergency medicine and critical care. So that one doesn't need to be a factor evaluated in difficult airway. We already have assumed there's going to be a stressful situation because it is never routine. So that's why we don't talk about human factors. Experience. We never have trainees intubating alone. And if we have places in which you mentioned in one of your editorials, the emergency physician who does 10 intubations a year. Yes, that is going to be a bad situation. They should just assume they're going to have a complex airway experience, even though for you and me, it would be simple. So again, it's not really part of it from an individual patient difficult airway assessment. That should be a global assessment. Those people probably should be working in pairs whenever possible. They should be doing all the mitigation strategies. So it's not going to be part of our individual patient assessment. It's just basically goes into the approach you have to every airway. Now, if you're in a place like I work where we have a very diligent airway QA process and a demand for a whole bunch of factors that mitigate the individuality, then that might not need to be an individually assessed thing. Location. All of our airways are done in the same place. They're all done in the resus room of the ICU, or the location disappears. Equipment. We don't allow a situation like they have in the operating rooms where if you want to have even a video laryngoscope, sometimes you have to call for it. And then someone has to go into the core and see where it is, or it's kept in certain rooms, or it has to be found. In emergency medicine, critical care, the way I have taught airway for years now, every intubation is a video laryngoscopy. There's no more direct
but this is the American background.
Absolutely.
And
So what we're left with
from an American context.
Absolutely.
Yeah.
But my podcast is on not just an American background, but my background.
Global.
That's all the podcast is. So we're now left with two of the help it factors, which is patient factors and time pressure. Time pressure is physiology, at least the way you've defined it. And patient factors are anatomical for the most part. When I talk about the two domains that need to be assessed in my airway podcast, I'm not seeing yet where it is outdated.
Yeah, maybe outdated is not the correct term. So maybe we should find a new phrase to call your teaching. I think from your background, in your context, this is the most ideal way you can teach. But if you look at this from an educational prospect, and if you want to learn other people finding their way into different countries, hospital situations, you cannot only teach your own way. This is how I do it, because these people will not stay in New York. They will probably go to Texas or they go to the Netherlands, and they will end up in a totally different area situation. And with my background from the Airway Management Academy, I've been teaching in many countries and also low-income countries. We try to help as many people as possible with airway management. And I think if you look at the location domain or equipment domain, even in academic centers in the Netherlands, I work there sometimes as a locum, there are still academic centers with over 25 operating theaters. They only have 4 video rooms.
Now, I don't know if my point was really received yet, because we're still talking about locations in the world and different places in the hospital, and that definitely has validity, but it's not really the main thrust of what I want to get across. What I was trying to relay is that it is a fundamental difference between emergency and critical care mindset, which I'll call resus airway, and the airways practiced in anesthesia. And the reason why is a set of assumptions that we make in resuscitative airway. So what I'd love to do is walk you through the help it categorization that Hans mentioned, because I think it's a good one. And then I think you'll see after what I'm talking about in terms of the different sets of assumptions. So let's go with first H, which is the human factors. So the 3 on here: language barrier, fatigue, and stress. Language barriers really don't play a huge role in the emergency medicine airway in terms of our interaction with either our team or the patients. Fatigue, luckily, in emergency medicine at least, we don't work shifts beyond 24 hours, and most of us are working 8 to 12. So fatigue is not as big an issue. And even if I was at the end of a 24-hour shift, airway management wakes me up quite nicely. I don't find this is a big one. Now, stress is omnipresent in resuscitative airway. We just accept it. There is no airways we're going to run into where the stress is not there. So it becomes a consistent factor in our airways versus, oh, I came in thinking this was going to be routine, a regular operative elective case, and it turns into something very different. That's not our world. All of these patients, we are in the mindset already of, crap, these patients could die peri-intubation. We already have the stress going in. We've learned to mitigate that stress globally, not on an airway by airway basis. Experience. This one is not as important in our specialties where trainees are not going to be intubating without supervision, without the supervision of a consultant or an attending, or at least, and in the critical care realm, a fellow. Though honestly, I'm going to make some enemies here, but if you're a fellow intubating and you haven't come from an airway specialty, like you're not a critical care fellow who came from EM or anesthesia, I think you probably should be supervised. And that probably will mean if you're an internal medicine or neurocritical care or surgical critical care fellow, you probably should be calling anesthesia to be your backup. And I know that's going to make me enemies, but I'm sorry. This is how you eliminate the experience of help it, is by having someone experienced there at every intubation. I just don't think it's safe anymore in critical care and emergency airways to have that ever done by someone who is not truly experienced. And that could also mean if you're in an academic center and you are primarily research and you're doing an occasional clinical shift and you've never really developed the chops, or you did and they disappeared. But honestly, people who go into research, I'm not going to say across the board, but generally there's some self-selection there. I know some amazing researchers who are stellar clinicians. Brian Driver, I'm thinking of you, brother. But for the most part, people who want to go into a 2 shifts a month type world are generally not the sharpest clinical tools. Get a friend to help supervise that airway. Location of the airway procedure. Not really an issue for us. The location that makes it difficult for anesthesia, the out of theater environment, is our bread and butter environment. When anesthesia comes to the ED or to a critical care unit, it's considered to be de facto a more difficult intubation. We're used to that. That's our world. This is the place we are most comfortable. So location is not really an issue unless you're going to like CT scan or something. And then I could not be more strong in my urging to mitigate those location factors. So if you look at all my stuff, if you look at Hennepin Airway, one of the best airway places in the country for emergency medicine, we've all come to the same ideas, which is you don't just go there and use the intubation kit in their code cart. You bring with you all of the equipment you could possibly want, which means for my druthers, the EMCrit dump kit, which is a fantastic bag, in my humble opinion, that lets you actually have the exact way you want airway equipment laid out wherever you go in the hospital. It's already prepared. You don't have to open stuff. It's just there for you. Check out the site if you want to see more about that. You've brought with you end-tidal CO2 in a portable fashion. You've brought with you a video laryngoscope in a portable fashion. And all of the difficult airway equipment you might need, your bougie, all of the stuff you're going to use on the first pass, all of the stuff you're going to use as rescue, it's all there for you to completely mitigate the situation of being in a different location. If I have to intubate in CT and I bring the stuff I want that I've already set up and it's ready to go, there's no difference for me in a CT intubation or a regular one. For all intents and purposes, it's the same intubation. We have the same monitors in our CT scanners as we have in the department. It's all the same. If you are following my wishes and wants in terms of how drugs are managed during emergency airway, it's going to be drawn up whether you're in the department or you brought it with you in a drug bag out at CT in that alternative location. Same thing, if you're a critical care person intubating on the floors for a patient that's crapping out, it should be the exact same equipment you have when you go to intubate in your own unit. All right, then we get to P, patient factors. I'm not going to discuss it because Hans and I both agree. This is something that needs to be assessed. I spoke about this during the DAS Airway Guidelines podcast I did at the top of the year. that sparked this debate. I'm not going to go through it now. I think we discuss it a little bit later on, that we do have very comprehensive sets of questionnaires that have been validated in the literature, things like Makocha, that will give you the questions you need to ask to understand which patient factors. And there are some nice ones in the Airway Triage app as well, though I think not as relevant in our world as the Makocha ones, but very nice ones that would cue you in. So if you don't have your own intrinsic ideas of what you should be thinking about, looking for, and asking, there's some very nice ones in the app. All right, then you get equipment. There should be no equipment issues that have to be dealt with in emergency medicine because, and this is the fundamental difference between emergency medicine, critical care mindset, and anesthesia mindset, is they escalate on failure or on anticipated difficult airway. Those are the 2 points they escalate, on failure or anticipated difficult airway. The rest of the airways, the unanticipated difficult ones that occur, they have to escalate when they fail, or maybe when they feel there's a high chance of failure. They get in there during their first look. They're like, I don't like this at all. I'm going to take a second look, but in the meantime, I'm going to call for equipment. That's not the way it's done in resuscitative airway. In resuscitative airway, we escalate early. We escalate empirically. I discussed this in another podcast called You Suck at Airway, which went into all of the philosophical differences between anesthesia and emergency medicine critical care airways. And I just need to make clear, if I haven't made it clear enough already, there is nothing wrong with the anesthesia mindset or philosophy. It is perfectly appropriate to their world. And the Airway Triage app is wonderful for anesthesia because it would allow them to take situations where there's going to be an unanticipated difficult airway and shift it to a difficult airway. But it's not our world. In our world, we pretend every single airway has the potential to be difficult. We've already checked those boxes. If Hans asked me, hey, Scott, you're going to intubate. I don't need to know anything about my patient. Is it going to be advanced? Yes. Is it going to be complex? Yes. Without even seeing the patient, without the patient even existing. And therefore, that's why it's not important to use this Airway Triage app, because the questions it could answer have already been answered. They're already advanced. They're already complex. Boom. They're already advanced. They're already complex. The Airway Triage app does not have anything to offer me because I have already answered the questions in the affirmative every single time I manage an airway in emergency medicine. And Hans is like, well, Scott, your philosophy is different. Might be, but that means the people in resuscitative airways have the wrong philosophy, in my opinion. And they should adopt that. Rather than adopting the Airway Triage app, they should simply adopt my philosophy, which is they're always difficult, they're always advanced, they're always complex. And then it just becomes a question of how complex are they? How complex are they? That's the decision we make. We actually add an additional shading rather than less shading. We're not outdated. We're not old school. We are more advanced in our assessment because we're already in the space of complexity. And therefore, we have gradations within that complexity. Is this a patient who's complex and I'm going to escalate early, or is this a patient who needs to be managed with an awake intubation, a spontaneously breathing intubation? Those are the questions we're asking, and they're not questions that are answered by the Airway Triage app. I could easily create a Airway Triage resuscitative airway set of checklists, and maybe, Hans, I'm happy to work with you on that. That would answer those gray zone questions. But the Airway Triage app in its current form is not answering the questions I want. Now, I went on a diversion from the equipment. So what do I mean by we always are making that assumption? It means, first off, we escalate early. We're going to use a bougie on every single intubation. Or if we're using hyperangulated, then unless we have a manipulable bougie or a bougie that is matched to hyperangulated geometry, like the USB by my buddy Rich Levitan, then we'll use the stylet. But I prefer you to use the bougie because then you have to only achieve single technique mastery. So, bougie on every intubation, video on every intubation. And Hans is going to be like, well, Scott, you're totally New York centric here. No. If I was working in a different part of the world and I had the salary or the means, I would buy my own video laryngoscope. They're not expensive now. Now, if I'm a doctor who doesn't have a salary, I'm not just, doing moonlighting or, just doing a rotation somewhere, then of course I have to adapt to the local circumstances. But I think in a vast majority of the world, not just New York, the ability to have video laryngoscopy on every resuscitative intubation is not too hard an ask, because we don't need to have one for every single operating theater like they do in anesthesia. We just need one for a department or one for a critical care unit. Just one, because we don't do simultaneous intubations at 30 separate rooms throughout a operating suite. So it's really is doable to have that ability. And then we also have all of the rescue immediately available in the room. So we have the capability of supraglottic airway placement. We have the capability of surgical airway. And we're trained for that. And another contradistinction to anesthesia, where it's not really within the standard skill set. Yes, they will always put surgical airway there. Most anesthesiologists are not comfortable with it. And even if they practice the skills, they're not willing to do it. They'll often wait for a surgeon, which is no slight. And there are plenty of anesthesiologists that will do it, and I applaud those folks. But in emergency medicine, it's an expectation. It's a basic competency that you're capable of performing your own surgical airways. In most places, I feel you should have disposable video bronchoscopy as well as something in every airway room or immediately next to whatever airway room you're in, if like there's two adjacent resus airways and only one room has it, such that equipment is not really an issue. Time pressure. This is the thing that speaks to the physiology within Help It. Every single patient should be assumed to be physiologically difficult in resuscitative airway. And it's just a question of, are they physiologically difficult enough to mandate spontaneously breathing intubation? So really, what I've been trying to get across is we only have two questions that matter in resuscitative airway. Patient factors, i.e. anatomy, and physiologic factors, i.e. time pressure, as Hans puts it in the app. And as such, those are really the only two that have been necessary in my experience, and I think that's extrapolable to anywhere. And therefore, it's not outdated, it's not old school, it's pertinent to resus airways. Now, if you're not doing all the other stuff I mentioned, if you're not making all the assumptions I said, then you got some stuff to fix. And I don't think the Airway Triage app on an individual patient is the way to fix those things. This needs to be fixed globally. This needs to be fixed in your department. What you need is an airway lead. See the paper I wrote on the airway lead, who's going to force the issues to get the other four factors made not relevant on any individual airway because they are taken care of globally. I hope that is a better explanation of what I've been trying to get across in this discussion.
And then often it is the guy who screams loudest gets the best equipment and the timid and shy people will not get it. And of course you can probably intubate 98% with a dialect laryngoscope, but it's not an ideal situation. And I think if you look at the Airway Triage checklists and apps, I always had problems teaching, and you probably have the same because you are so experienced, and even as an experienced doctor, we don't have the tools to make airways understandable because sometimes I rush in, I say, give me the tube, I stick the tube in, and nobody learned anything because I don't know how I did it, and the learner thought, what did I do wrong?